All right. Well, Dr. Memi just showed you how hard it is to translate some of those benefits that we get from skin melanoma to other melanomas. It's even harder to translate it to other cancers, but it's happening. And the main indicator of that is how we're utilizing these therapies even before the cancer spread to other organs in the adjuvant and neoadjuvant. What the hell does that mean? Because we've been throwing those terms around. Well, I can't do it as I can't give that talk or educate you as well as Dr. Patel, Dr. Sapna Patel, who is a leader in that field, and is then last year we kept saying MD Anderson, and now Dr. Patel has moved her expertise to the University of Colorado, and I've got to get used to saying this. She is the William Robinson Endowed Chair Professor in Cancer Research. And we celebrate that and the recognition of all the work you've done, which she will tell us about right now. As you don't need a timer.
11 minutes. Thank you, Dr. Hamid. I just realized I made a boo-boo. So this talk is only going to be about neoadjuvant therapy. I didn't actually include anything on adjuvant. I just realized. So neoadjuvant, neo means new in Latin, and then adjuvant means alongside, basically. So lovely. Don't look, close your eyes. So adjuvant therapy is what we give people after primary treatment. So after a primary tumor and or lymph nodes are treated, is there something we can do to reduce the risk of cancer spreading? Neoadjuvant is something you might do before treatment of the primary tumor. And it may come with some adjuvant therapy post surgery, if you will. Some people are using the term perioperative because that more clearly explains that it's something done around the time of surgery, before or after surgery. So one of the first questions, I think, is there any rationale for giving medicine before taking out a cancer? And it turns out there is. There was a nice, you can just picture it in your head. There was a nice breast cancer model that did this, a mouse model that said if we inject a little breast tumor in the mammary fat pad, so essentially the breast of a mouse, and then just let it grow into a tumor and take it out and look at the immune system, how much immune system do you have after the fact? And if we actually do some treatment, and in this case, they did a type of kind of tetanus diphtheria toxin, which is known to stimulate an immune response. If they give that while the mammary fat pad tumor was growing, would you get a bigger immune system after taking out that tumor? So when they compared those mouse models, they did see a bigger immune expansion in the blood of the mouse. So that was really the original. Oh, here we go. Slides. That was the original model for neoadjuvant therapy that was sort of modeled, if you will. Boop. Boop. Boop, boop. I went back to. Right. Yeah. So then this was done in actual melanoma patients, just as a pilot study. And they took 20 patients and gave 10 patients who had their melanoma that was able to be removed. They took it out and gave them what we call adjuvant immunotherapy. Let's try. Yeah, here we go. Okay. So questions, answers, this is where we are. Is there rationale? Sure, there is. This is the breast cancer model, but here's the sort of skin. This is just a cartoon. This is not, obviously, this was not done, but the idea in the top is if you take out a tumor and then give some drug therapy, you'll get some of these colorful circles, immune cells activated. But if you leave the tumor in place and give the drug, then those Y molecules actually get a bigger number of these circles, as you see. You can still take the tumor out, but the idea is you're left behind with more of this circulating immune system that can then go off and do stronger work. So that's the rationale. And, I guess before we get to that pilot study in melanoma humans, It's important to recognize what the scientific method is. This is how we properly test things in, across science, but in medical clinical trials. You make some observation that it may make sense to leave a tumor in place for a short amount of time to expand the immune system, but then you have to design an experiment around that. And then you have to have some hypothesis of what will happen. We hypothesize the immune system will be more expanded if we leave the tumor in place for a short period of time. But then you actually have to test it, and then you have to describe your observations. So, sometimes you make slime and the slime looks good, and sometimes you make slime and it bubbles over. So now you have to go back and say, okay, what actually happened here? What did I observe? And then it's iterative. You go back and do that again and again, and make your observations, make a experiment, hypothesis, design, or describe your results, etc. So this is how we kind of do things, and it all starts with a pilot study, which is what this opacin trial was. This was the optimal dosing. The way to sequence immunotherapy perhaps before you remove a tumor. And so what they actually did, let me see if I can use this pointer. The pointer is, which one is the pointer? The red, right? Okay, well, it's not working. All right, it's fine. In the adjuvant, in that red bar up top, they had these melanoma tumors, took them out and gave them adjuvant therapy in 10 patients. And then in another 10 patients, they gave them treatment first, then took out the tumor, and then more treatment on the back end. And essentially what you see in that blue group is you got the bars are taller. So you got more of an immune system by leaving the tumor in place for a short period of time. And you got new T cells emerging. So that's the faded, the lighter color blue, if you will. So you got kind of essentially more clonal expansion of new T cells, new detected T cells by leaving it in place. This is all nice. So this tells you what they found in mice and breast cancer you could somewhat replicate in human melanoma patients. But in the end of the day, does it prevent the melanoma from coming back? Do you live longer with this strategy, or is it just a nice way to boost your circulating immune system? So this gets to the question, let me go back here. This schema gave 2 rounds of immunotherapy combination while leaving the tumor in place. But could you have done 1 round, or could you have done all 4 rounds? How much immunotherapy do you need while leaving a tumor in place? And that gets to how much duration of this preoperative therapy and maybe adjuvant therapy do you need? So this is a slide that describes all of the essentially single and double institution trials that looked at this preoperative and postoperative, perioperative, if you will, approach, with the gold being the preoperative regimen duration and the blue being the postoperative. And you can see it's across the board, right? There are some medium regimens, 8 weeks, 12 weeks, 6 weeks, 12, 3. There are some regimens that have no adjuvant therapy. So that bottom group, they just gave the preoperative with no postoperative. There are regimens that gave a full year. There are regimens that gave a total of a year, half a year. So do we know the optimal duration? Based on this, there's no unifying answer, right? You could say, you can't draw a straight line and say this is exactly how much to give. So the answer is we don't know. And even this International Neoadjuvant Melanoma Consortium doesn't know, which is okay. It just means we're just still experimenting with different durations. But I would sort of, for the scientists in the room, I would remind us of some of this very, very early data in the metastatic setting. The way these immunotherapies work is typically they're blocking a receptor. So they're blocking an interaction on a tumor in the immune system. And we call that receptor occupancy. When you block a receptor and you sit there for a period of time, it doesn't just block it and fall off. It blocks it and holds on to it for many weeks. And so the question is, how many doses until you get excellent blockage of that receptor? From our metastatic data, this is way back, 12 years ago, we knew across different dose levels of the drug that turned out to be nivolumab, after 4 doses of every 2-week dosing, so, this is about 8 weeks into therapy, The receptor is saturated at about 60 to 70% after 4 doses. And it doesn't matter what your dose was, whether it was one of those low doses, 0.1 milligrams, or one of these higher doses, 10 milligrams per kilogram. You're about 60 to 70% saturated. It still doesn't tell us how much of that happens after the first dose, how much of that happens after the second, third, and fourth. And theoretically, we could design a trial like that, where we actually gave patients who have resectable melanoma these single doses, 2 doses, 3 and 4, and we look at this endpoint that we look at in perioperative trials called event-free survival. We could also look at receptor occupancy. So we could see how much of the receptor is actually blocked after 1, 2, 3, and 4 doses, and maybe try to get to this answer of the optimal dose. The point being, if a lot of it is blocked after that first dose, then second, third, and fourth doses may only be adding to toxicity and side effects and not so much efficacy or effectiveness of the treatment. Okay, well, that's all nice. That tells you we've got some rationale. But do we actually have any randomized data in this setting, in this perioperative or pre and post surgery? We do. There's a couple of trials. The SWOG S1801 trial was a cooperative group trial that we ran in the US, where we randomized patients essentially to how that Opposite trial was done. Patients who had resectable melanoma could get randomized to the standard of care. That's the top row. So they would have surgery and then a year of standard pembrolizumab post-operatively in the adjuvant setting. Or they could have perioperative pembrolizumab. So they would take 3 doses before surgery, then go to surgery, and the remaining 15 doses in the adjuvant setting. So this study just said, same treatment, let's just split it up and sequence it a little differently. And what we found was actually the group that took it before and after, the neoadjuvant adjuvant group, could call this perioperative, they did better in terms of melanoma events than the group who took it all post-operatively. So this was randomized now human trial data that said you do have better outcomes. It doesn't answer the question that original Opposite trial showed, which is, do you have more circulating immune system? We haven't shown that. We haven't looked at that yet. This is just the more clinical, tangible endpoint is, do the patients do better? So we hypothesize that it's due to a boosted immune system, but clinically we see that these patients are doing better. And this is just a side note. We didn't put the hazard ratio in the New England Journal paper because we had this cranky statistical reviewer who kept fussing with us and said, you cannot put this hazard ratio. These are non-proportional hazards, which is only to say they didn't think our 2 groups were actually proportional at baseline, which is false, but because you entered the study and then you got randomized, so they were proportional. And all these other neoadjuvant therapies published their hazard ratio. So we had this cranky reviewer, and we just decided better to get it published than to fight with the reviewer. We submitted the paper in August. It was actually in print in March, and we were accepted in December. So it's this long road. And if we had kept fighting, no telling how long. But what the lesson learned is that regulatory agencies around the world, so Finland, Denmark, all these countries are looking for that hazard ratio for their health ministries to approve these therapies. So the absence of that hazard ratio really caused a lot of these global health agencies to have pause about accepting this regimen. But nevertheless, so that's that. Okay, so once again, this study, this randomized trial really only tested one hypothesis, and that was you have a fixed amount of pembrolizumab. Can we just alter the sequence? It doesn't tell you that we chose the optimal sequence or the optimal duration. We said 3 doses, but maybe 1 dose would have been enough. Maybe 6 doses would have been better. It was just a single question, and we chose 3 doses just because it approximated a reasonable amount of treatment without delaying surgery too much. Now, there was another randomized trial in this perioperative space. Really, this was a pure neoadjuvant preoperative study, and this was an injectable, essentially light herpes virus, a deadened herpes virus that we inject into tumors. And herpes is essentially a very strong stimulator of the immune system. So you inject a non-infectious herpes variant into a melanoma tumor. It will stimulate the immune system and it will draw it over to that tumor. And now that immune system will say, well, what's all this melanoma stuff? And start to treat that. So this is an injectable therapy, TVEC, telimagene laherparepvec. And this simply just said everybody either goes to surgery or we inject them 6 times. So this is over the course of a few months. We inject that melanoma tumor 6 times and then we remove it. And it turns out doing that injection did give you a better survival. So that's the gold arm here. And you see it not only in that recurrence-free or what we call event-free survival, really it's a recurrence-free survival here. You see it overall, those patients who got the injections did better. But this is, not a typical way we're treating melanoma right now. We're not injecting it before surgery. There's also some caveats about like how the study was done. It wasn't done in the United States. And we always take a little bit of pause if we don't have actual US patients in these trials. Is the data sort of real world enough for us? But having said that, this was another randomized trial that's out there in that space. So now the question is, if it looks like leaving the tumor in for a period of time and doing something, whether it's immunotherapy, via vein or injecting some form of immunotherapy, if that looks like it's beneficial, are we ever going to get to the point where we can do less surgery for melanoma? So it's no longer a lot of surgery, lymph node dissections, et cetera. And can we do less post-operative, so less adjuvant therapy? So how do we answer that question? The Prado study attempted to answer this. Now, this Prado study, I make the point when I look at the slide, it's a really pretty slide. It's a pretty schema. But it's important when you think about that scientific method. That scientific method is testing a hypothesis. And this is not actually controlling for any of the variations. So this slide looks very pretty, but it's not a randomized trial. So there's no randomization here. You just start marching down the study. And if you have the green outcome, you go into that group. If you have the gold outcome, you go into that group. If you have the red outcome, you go there, but you don't randomize. So you don't randomize green versus gold or green versus, this regimen versus another regimen. That's all to say it's still an excellent study. It is a personalized strategy. So if this happens, then you do this. If this happens, then you do this. As a result, there's a number of variables that ended up here. So this study de-escalates surgery and adjuvant therapy, and you see that in that final column of boxes. If you have an excellent outcome at surgery after being exposed to pre-surgical immunotherapy, you're finished. You don't have to have a big surgery, and you don't have to have adjuvant therapy. The partial responders, the gold box, had a full surgery, but they did not need to have post-operative or adjuvant therapy. And so those are just additional variables introduced into the analysis of this. I think that's my monitor dinging here. Okay, so this study had a very interesting outcome for these major pathologic responders, this green group of patients. They're doing very well. You see that tail or that plateau developing for these patients. They're clearly doing very well. But the hypothesis, we go back to the scientific method, what was their hypothesis? The hypothesis was that none of these patients who accomplished a green outcome would have a recurrence. So nobody would recur in the first 2 years. And they did have 4 of these recurrences in the first 2 years. So technically, by that endpoint, this was a negative study. Their hypothesis was something, they didn't meet their hypothesis. So they went back and looked at their observed data. They also said in the gold group, this group didn't do as well as we thought they were going to do. Based on the prior experience, they thought this gold group was going to be fine just having surgery and no adjuvant therapy, but they ended up not doing so well. So this helped them think about kind of the next trial design, what to do if you have a gold outcome, you probably still need some adjuvant therapy. And so there were 2, it's a very, very important study because it shows us that we can kind of revise or iterate our hypothesis based on previous findings. Now, this is that same green curve that we see here. I'm just showing it to you isolated here in terms of relapse-free survival, so the melanoma coming back, and that's in any form, at the lymph node site, distantly somewhere, and then just the distant survival. So did the melanoma come back somewhere distant from the original? So what's interesting is there were these 4 patients who developed a recurrence. And remember, this is the group that didn't have a full surgery and didn't have adjuvant therapy. And what the authors are saying is, well, when the patients entered the study, these 4 patients had multiple lymph nodes involved. So they may have been patients who, were going to have some recurrence. We maybe could have picked them out because they had more than 2 lymph nodes, not just 1 lymph node involved. And they were raising the question, well, would we still ask this whole group of patients to undergo a full surgery when only maybe 4 recurrences happened? And ultimately, we only had 28 patients who had more than 2 lymph nodes, and it was still only 4 of those 28. Does everybody need a full surgery? It's only 14% recurrences. Would we subject 100% of these patients to a full surgery? So the conclusion of the authors is that you could probably omit surgery for everybody. I will just make the caveat that that's a fairly controversial statement, because if you as a patient are one of those people in whom the melanoma recurred, you may have preferred to have had that big surgery up front because you don't want to have a second episode of melanoma, et cetera, et cetera. So this is a little bit controversial. It's which perspective you're looking at it from, the 14% or the 86%. Okay. What else is I going to tell you about this slide? That's probably it. This is the real question. If we know somebody has multiple lymph nodes involved at the beginning, should we maybe keep the full surgery for them? It's still going to only be a minority of those patients who have potentially a recurrence if we omit the surgery. But are we doing the greater good here? That's a philosophical question, I guess. The last thing to say about this trial is that omission of surgery is still considered a little bit controversial in some of the surgical literature. So could you actually remove the surgery for all of these major path responders? We're not sure. And there's this editorial that suggests that a full surgery should remain the standard of care. And for that gold group, that group that has a kind of an intermediate response, could you just do surgery? Do you not need the postoperative adjuvant therapy? That's not really clear either, because that group certainly didn't do as well as hypothesized. So where do we go from a study like Prado? They used all of that information and built it into this randomized study called NADINA. And NADINA is a global study that randomizes patients to the standard of care, which is the bottom row. So a full surgery for their melanoma and then post-operative therapy for a year. Or they get randomized to the NeoAdjuvant, which is 2 doses of immunotherapy. And then based on what happens at the full surgery, if they have excellent tissue response at the full surgery, they're done, no adjuvant therapy. If they have less than excellent response, then you'll get some form of postoperative or adjuvant therapy. So NADINA is finished. The study has finished enrolling, and the real kind of big news is that we should stay tuned. And what are we, like 3 weeks away now? 2 weeks away from hearing this? What date is it? Today's the 11th. So we're about 3 weeks away from hearing the results of this. This will be in the big plenary session at ASCO, so our big international conference, and we will hear the results of this NADINA study with a good discussion by Harriet Kluger and Christian Blank, who's really the leader in this neoadjuvant field. This is who you should have come speak at your Angeles Clinic forum, because put him on a ship. He'll come by boat. He'll swim. He's a swimmer. So Christian did that original opposite work, that pilot study work of 10 patients in melanoma, and helped optimize, how we invert the doses in the neoadjuvant study. I mean, he really is a leader, and this is such a wonderful opportunity for him to showcase this big NADINA trial. Okay, so that's talking about, perioperative, and we're going to see some nice randomized trial data on combination immunotherapy. What about that postoperative? What if we gave everybody the same neoadjuvant regimen? We gave everybody the same surgery. How do we determine how much postoperative we need? If we go back to NADINA, remember here, we're not really controlling for what happens in green and pink here. So what you'd like to see is major pathologic responders. Then you get randomized to dropping adjuvant therapy or continuing adjuvant therapy, right? And then you could say, okay, they do or do not need adjuvant therapy. But here we're just dropping it. So if they do well, that's great. But if they don't do well and there's some recurrences, you'll question if they needed some adjuvant therapy. So what if we just did that trial, which is give everybody the same regimen, take everybody to surgery, and then randomize them to no adjuvant therapy, some adjuvant therapy, half a year, the full year, which would be 10 if you give 2 rounds before surgery. And then you start stratifying them by how well the tissue responded. This would be a large study, but it's completely doable. And so this is something where we could actually figure out how much post-operative therapy people need. Okay, what's the next question in this space? It's really, if we are now adopting this perioperative approach, and globally, this is really now being used for resectable or operable melanoma. So Australia can offer perioperative pembrolizumab now. The UK can do it. Ireland can do it. There's some countries in Europe that can do it. They can do it with single agent immunotherapy at the moment. After Nadina, hopefully they can do it with combination. So you're now using these regimens. The patient is sitting in front of you. They've just had their surgery, and you've given them that pre-surgery treatment. The most important question, I think, is not to discern if you've had an excellent outcome, because we can always, we do this comparison thing where we say, did this patient have the best outcome? Well, they can only have one outcome. You can know in your head that there's another patient that can do better, but that's not helpful for the singular patient, right? The real binary question for that one patient is, are you happy with this response, or are we feeling that it was unfavorable? Not did they have the best response, any patient can have, because that doesn't help anybody. So the way I like to frame this is, okay, now you've treated the patient, they're sitting in front of you. Are you going to say to that patient, I'm happy with what's happened, we have a favorable response here? Or what is the sign of an unfavorable response? So I frame it in unfavorable because I think it's a little easier to put your head around. So we went back and looked at our SWOG trial, and we said, okay, if we look at the tissue response after those 3 doses of pembrolizumab given before surgery, take out the melanoma and we look at the tissue response, what happens? How does it separate? And it turns out it separates into 2 groups, right? You see those 2 groups at 2 years here and here. I guess I just because I circled them on the slide. I cartoon circled them. There we go. So there's a group there that clusters together. And you see in the table here, they have essentially the same 2-year recurrence-free survival, 87, 88, 89. Does it matter what shade of blue you got? It really doesn't, right? So you just want to tell that patient that's sitting in front of you, if they ended up in that bucket, you're happy, right? You're not unhappy if they had a non-response, let me clarify, but you're happy that they had one of these higher responses that bundles together. But what if you don't really have, the pathologists aren't really technically reading the tissue that way? What if you just use the radiology scan that you got before surgery? The patient had the treatment, you had some scan that showed their lymph node, then you had the scan right before surgery that showed the change in that lymph node, hopefully a decrease. Are there 2 groups here? It turns out there are 2 groups here. So there's the group that basically had a complete response on that imaging or a partial response, or stable disease or progression of disease. So we have 2 groups there, and they also segregate there, you see, with similar numbers for radiology. So now you've got the patient sitting in front of you, and you say, well, I like what happened to your lymph node before you went to surgery. So again, you're feeling, what favorable is. So then what is the sign of an unfavorable response? So let's go back and agree what we think favorable is. Favorable is we didn't give them any major side effects. We didn't give them any major side effects that we lost that surgical window. So they still went to surgery on time. We didn't have any progression of their melanoma before surgery because the melanoma was left in place. The risk that, and the fear that some patients would have, which is fair, is, well, or if we leave the melanoma in place, isn't it just going to spur on more melanoma? So as long as we don't have melanoma spreading before surgery, that's favorable. Can you get to surgery and still get all the melanoma out? That would be considered favorable, right? We want all of that melanoma out. Can you get the postoperative therapy? And I say that only because we're not really sure right now in whom you can omit that postoperative adjuvant therapy. So as long as you can receive some, we would think that that's probably favorable. And then ultimately the biggies, right? We want no melanoma recurrence and we want no deaths from melanoma. That's really favorable. Now that's a longer outcome, but that's going to be our favorable response. And as we expose people to more immunotherapy, we want the toxicity to be manageable. We don't want to leave somebody with a lifelong problem. We've fixed their melanoma and then we've given them this other thing. Ideally, we want to fix their melanoma and not give them a major side effect. Okay, so if that is all favorable, then I hope it makes sense that the opposite of those would be unfavorable, right? So if we get side effects and we lose our surgical window, that's unfavorable. That's how I would sit in front of a patient and say, gosh, I'm a little bit disappointed in myself that this regimen caused this side effect and we lost our surgical window. If we leave the melanoma in place and it does spread, boy, that's unfavorable too, but that's probably telling us the bigger picture about the biology of that melanoma. Taking it out may or may not have stopped it from spreading. If we can't have surgery to remove all of it, so the melanoma can grow, that's okay. Melanoma growing is not a failure or unfavorable response, because remember, we still have surgery on the table. We still want surgery to remove it, as long as that can happen. But if your melanoma grows or spreads in a way that the surgeon can no longer take care of it, that would be disappointing. That would be unfavorable. And if you can't get to your postoperative therapy because the surgery was too hard, the preoperative treatment was too hard, we developed some side effect, and now it's contraindicated to give you adjuvant, that would be considered unfavorable. Obviously, if the melanoma recurs, that would be considered unfavorable. And then if you have one of these lifelong or serious side effects. So my answer to what's unfavorable, it's the opposite of what we're considering favorable, right? We like all of these things. If a patient comes to me with basically the opposite, I would say, oh, that's unfavorable. And I say it that way because there is this feeling amongst our oncology brains that patients need to take a little bit of preoperative therapy and have all of their melanoma eradicated. And now we don't need surgery, and now we don't need adjuvant therapy. And if we don't achieve that, we're not happy with the result. But that's not true. That's not true. Just like you saw, Dr. Hamid showed you patients who have a complete response do well, partial response also has a tail of the curve. And then we have two other groups maybe that could be doing better. But once you're on that curve, if you're a partial responder, that's where you exist. Are we happy with the partial response or are we unhappy? Most people wouldn't be unhappy with it. We would just in our head do, I know there's a better outcome we could have. So just because your melanoma was not completely eradicated after your preoperative or perioperative regimen, it doesn't mean you had an unfavorable response. It means there's a better response out there, but it doesn't mean that the response was unfavorable to you. I'm getting a little bit philosophical here, but that's true. So ultimately, the sign of unfavorable response to perioperative therapy would be a recurrence of the melanoma. We would say that perioperative regimen then didn't work. So what is the goal of neoadjuvant therapy? Is it to eradicate all the tissue evidence of melanoma at surgery, a complete pathologic response? That's an optimal outcome, but that's not the goal. The goal, remember, is to boost the circulating immune system. And boosting the circulating immune system doesn't speak to eradication of the tumor in a short amount of time. That eradication may still take weeks and months and years. So complete pathological response is nice, but it's not required. It does not have to be the goal. Similarly, complete radiographic eradication, I can no longer see the melanoma on your scan. That's nice, but it's not required with a short course of neoadjuvant therapy. The real goal of neoadjuvant therapy is number 3 up here. It's to stimulate an intact immune system, leaving the tumor in place in situ to produce a more diverse and expanded T cell system while maintaining operability of that tumor. So if the answer, what is the goal, is number 3, what's the sign of that? How do we know that we've accomplished number 3? Well, it's going to be melanoma recurrence. If the melanoma never recurs and you live your entire life, melanoma free, then we know that that treatment has worked. We can say it's going to be boosting this immune system, et cetera. We need markers for how to measure that. So the pathology and the radiology may be surrogates of this. If you have a complete eradication, it may be surrogates. Although remember, that earlier study had complete eradication and there were still some recurrences. So we do need some more validation of this. Okay, the bigger question is, are signs of an immune response important when we do this perioperative immunotherapy? Of course it's important. We want to see signs of an immune response, but what does that look like? So when we take out tissue after exposing it to preoperative treatment, there's an entire chain of custody that has to happen. The medical oncologist has to tell the surgeon, hey, I gave this patient preoperative therapy. The surgeon then has to label the specimen as having been received with perioperative therapy or exposed to perioperative therapy. And now the grossing technician, a technician who sits in the operating room's tissue window, has to section this tissue very differently than if they were just looking for melanoma, yes, no. After you've been exposed to preoperative immunotherapy or therapy in general preoperatively, it's not just a melanoma yes, no question. We think it's actually how well did this treatment work, right? Which maybe is not the right way to look at this tissue, but this is certainly what the guidelines suggest right now. So that grossing technician has to section this tissue far differently than if they were just to get a lymph node and bivalve it, cut it in half and say melanoma, yes, no. They actually have to thin slice this technician, and now the pathologist has to read each of these thin slices. And this is not really accounted for in the way we bill, pathologists bill for their time, et cetera. The pathologist is now looking for these different categories of response. Do they see fibrosis? Importantly, hyalinized fibrosis. That's the sign of a long-standing immune response. Do they see pigmented macrophages? So not melanoma, but actually the little Pac-Man cells that are eating up melanoma. Do they see necrosis, and do they see viable tumor cells? They then have to do math, and they have to do this on every sectioned slide from that lymph node and melanoma. Historically, all they would be doing is cutting that lymph node in half and saying melanoma, yes or no. So this is a much more time-intensive process for pathologists. And then they have to apply this response categorization. So based on how much residual viable tumor, is it a complete response? Is it a near complete, partial, or non-response? And that's complicated, as you can imagine. So my point here is, if you look at that SWOG trial one more time, that randomized trial where we gave the pre and post-operative pembrolizumab, you see there's two groups, right? It's any type of response and non-response. It's not saying you must know if it was a complete response, right? So it's not a pathologic complete response and anything other than that. It's any type of response and non-response. So could we simplify this criteria so that the pathologist doesn't have to spend quite as much time doing it? That might help. This is getting a little bit in the weeds, but when we ran that trial at each of the individual hospitals, about 1 in 5 patients had complete eradication of their melanoma as read by that hospital's pathologist. But we asked all of those 150 cases to be sent in centrally. And we had one pathologist blinded to the results. Blinded Independent Central Review is what that BICR stands for. We had one pathologist look at it, and this pathologist doubled that number. He said it's not 1 out of 5. It's almost 1 out of every 2 patients that had a pathologic complete response. So how did that happen that the local hospitals were undercalling the complete response? So I went to the pathologist and I said, here's a couple of the cases where the local guys called it still viable tumor, but you said it was completely eradicated. Then he said, yeah, as I read it, they were reading some of that second column, pigmented macrophages. They were reading other things as melanoma that just weren't. So that tells us there's a big teaching curve. There's still a big learning curve for our pathologists to do this really complicated math. Remember, we're asking the pathologist to basically give us these 4 categories, do math on every slide, when ultimately all they were used to doing is saying there's still melanoma here or there isn't. But we're saying that even that needs some iteration and teaching. So maybe it's not how much melanoma remains after exposure to treatment. What's the other sign of an immune response? Maybe it's a quantity of T cells coming in, not whether the tumor is dead, because that might still take time, but maybe it's T cells rushing in, or maybe it's interferon gamma, which is the hormone that activated T cells secrete. So maybe we actually should be looking for that signal of an immune response, not eradication of tumor. I hope that makes sense, that they're on different parts of the equation. So the other thing I'll mention is that the pathologist, after the tissue is exposed to preoperative treatment, hopefully that tumor is shrinking, hopefully. And that pathologist is making an estimate of where the tumor started. Because remember, the pathologist doesn't have the preoperative sample. And we don't have it. We have radiology that says that lymph node was 5 centimeters. But radiology can't tell me that that entire lymph node had melanoma, that it was 100% contained. It's a 5 centimeter lymph node that might have had 3 centimeters of melanoma, right? But nobody knows this. These are all guesses. So the pathologist, as they are reading it on the slide, are guessing based on ghost cells that they see where the boundary of that starting tumor bed was. And if you ask any reasonable pathologist, they'll tell you it's a guess. It's an estimate. That's as much as they can do. It's also an artifact because the slide is only about an inch across. So you can only put about an inch of tumor maximum. So if you have a 5 centimeter lymph node, you're still not getting all 5 centimeters on a plastic glass slide. So this is a little bit of an artifact that's happening when we read these responses, which is again why maybe simplifying it might make it better. There's also a lot of controversy now in the pathology field on the impact of necrosis. So that's the third box there. Necrosis happens in melanoma samples before any treatment even starts. So some melanoma samples just have automatic necrosis. And now there's pathologists who say necrosis is actually a bad thing. Those are the patients who are having recurrence. This is not uniformly agreed upon. Other pathologists say, oh, no, necrosis that happens after treatment, that's different than originating necrosis. So if you can separate these two types of necrosis, so another type of separation, then you'll be able to see who's actually having a treatment response and not. So a lot of controversy still on how to interpret these. Okay, we're getting down to the end here. Is pathologic response looking at these tissue slides? Are we ready to scale this now? Can we take this around the world? Can we take it to every hospital? I think I might have just shown you, maybe not yet. We're still having discordance on complete response rates in the tissue. So where are we going to be? We're at the intersection of what we know today and where we can go tomorrow. I think most importantly, is to recognize where we don't have any evidence, where we're essentially data free. We don't know how to answer some of these questions. I don't know what saves us from a robot uprising. Frankly, I hate these CAPTCHA codes. They have some where you could just do the audio and they'll say some word. Even that's not that much easier either, because I can hardly understand. It's usually one of these speeches that somebody's clipped out of, and then you have to type the word pathological or something. So it's important to recognize where we're sitting in a data-free zone. I've shown you a lot of data, and the randomized trials obviously are the most robust. They have the most sort of foundational work to them. But where we're data-free, we still don't know what the best regimen is to use. We don't know if it's a single drug or combinations. More drugs leads to more side effects, but it also can lead to a stronger anti-tumor effect, probably also a stronger immune stimulation. But when you have a patient who's actually still able to have surgery, do you want to risk delaying that surgery because of side effects? Or we just don't know. We really don't know. So we probably need to figure out the optimal regimen. Maybe one way to do it is to start light. And then if you get that radiology response and you don't like it, you feel like it's one of the unfavorable ones, maybe then you escalate to combination, or maybe the inverse, who knows? Dr. Hamid was alluding to this relativity 048, where we're combining all the checkpoints that we now have approved. So triple therapy, maybe that's something we use, or maybe that's a little too toxic in the preoperative setting. Let's see. It's also important when we think of these side effects, there's different types, there's different treatments for those side effects. And as soon as we start using immune suppression and steroids, we're cutting the benefit of the immune system to give you a long-term benefit. But if you get something like a rash or vitiligo, that's different, right? You may not need to use as much steroids or total body steroids. There's also this idea of light touch steroids. The duration of that side effect is really important too. Some of these are really quick to turn around, and some last weeks and weeks and weeks and can really postpone your surgery. In the preoperative and perioperative setting, neoadjuvant setting, we're using this endpoint called event-free survival. And for the purposes of the SWOG trial, we defined that as not making it to surgery. You missed your surgery because you either had too many side effects or your melanoma progressed in a way that surgery could no longer remove it all. You could progress, you just can't progress in a way where surgery can no longer be done. It's not getting to adjuvant therapy, maybe side effects, melanoma progression, et cetera. It's melanoma recurring in any form, and it's death from any cause. So this was how we defined it, but there is no uniform definition here. So Nadina actually uses a different definition of event-free survival. And it will be important that as we start looking at these trials, we probably need to agree on what our definitions are. Otherwise, we're all just sort of defining it for ourselves, and then it'll be hard to make conclusions. So what are today's clinical questions? Well, what happens if you have one of these unfavorable responses? If we can finally agree, okay, well, this actually is unfavorable, what do? Do you change the treatment? Do you cancel surgery? I mean, we don't know some of these answers. And what happens if you have multiple lymph nodes and they don't have the same response? One lymph node has a complete and the other has a partial. What's actually driving that patient's outcome? One camp might say it's the least responding lymph node, because that's the one that's most in danger of giving rise to new melanoma cells. But the other school of thought might be, well, that complete response tells me that immune system's already kicked off and it's the immune system doing the work. It's not the melanoma to be afraid of. It's that we want the immune system to be working. So we don't know. We've got to sort that out when you have multiple melanomas in the specimen. Can we skip surgery altogether, particularly if radiographically you can't even see that melanoma anymore? Do we still want to do surgeries? We don't know. Maybe not. And then what about in that metastatic disease where it's operable? You could take out the one tumor in the lung or the liver. Does this pathology hold up, radiology, et cetera, et cetera? So just showing you those curves again, we definitely need more research on the biomarkers to help us guide. And the immediate next steps are to await this Nadina presentation at ASCO. This will be exciting. And then also, to really design smart surgery trials. And Dr. Ferries is helping to design one of these trials, looking at light surgery versus full surgery after exposure to this perioperative or preoperative therapy. We need to figure out the right regimen, the right durations, and we need better kind of science to support all of this. So that's where we are. Extra points, I'll buy somebody a coffee out there if somebody knows where this is from. This is a pretty cool saying I just saw. I was at a meeting last week and I really like this. A woman needs a man like a fish needs a bicycle. They actually had a fish on a bicycle, which I love a lot. So I'll thank you guys very much. And just wanted to say it's always fun to come to this meeting and see my friends here. And just in case you look at this and you think, gosh, Dr. Sullivan has a really small head. How does he fit all of that knowledge in that small head? This is a scale problem. That photo really doesn't show it. Look how tall Dr. Sullivan is. He's in front of a giant tree and he looks enormous. And even more so when he's holding his tiny little iPhone in two hands, he's dwarfing his little phone. So I'll cede the microphone to the brilliant Dr. Sullivan. Thank you.
Oh, look at that. We're on time. We will not have Dr. Sullivan come up yet. We will take a quick break after I make just 2 points. One, we just listened to adjuvant, neoadjuvant. It's not that we have solved metastatic disease, but the one point that was made on a little on the last slide is that all of this neoadjuvant work gives us something, tissue. It shows us how you respond. It gives us something, all the blood and all of the specimens on all of the information. Now, I have a patient who is a good friend who's here, and he said, this does not relate to me, but it totally does, because knowing the responses that you have with the certain features of your tumor can help us in the future biopsy someone who has metastatic disease and say, hey, look, it looks like this group of people that did well on this combination in this neoadjuvant trial, let's choose this combination. And I love it. You can always now, when you're at a meeting or talking with someone, seem like you're up to date and you know everything by saying just 2 little letters, AI. But AI in melanoma is taking all of this information, taking all of the slides and putting it in. And it's easy to say, oh, AI will do it. I don't know how it's going to happen, but it will happen. And we can craft better stuff. Those of you who know me, I love to talk about the fashion industry, because it's exactly what everybody wants in everything. You want to go to a restaurant, you want to have the food that you like in that restaurant, no matter what everyone else wants. You want to go to your oncologist and you want your oncologist to say, I have crafted this for you based on your tumor and what you want and what you don't want. If I talk to my patients, they would say to me, "Look, I don't want any colitis." Well, we can kind of figure out who gets colitis. Look, I want a great response. How do you're putting three things in front of me? How do you know which one works? The answer is AI and NA. Taking AI to understand the gains we've made through neoadjuvant therapy.